Good morning, good afternoon, friends and colleagues and well-wishers from across the globe. We welcome you all to our next ISCH webinar. ISCH is a scientific interest group devoted to promotion of all aspects related to clinical hematology, including translational and clinical research, also educational, and our goal is to dissemination of knowledge. I would say ISCH is a one-place shopping center for all your academic educational needs. Also, ISCH activities will keep you up to the speed in terms of knowledge to help our patient. Today, it is my great privilege to introduce my friend, colleague, Dr. Badar, to today's ISCH webinar. Dr. Badar is a hematology oncology faculty at Mayo Clinic. His specific interest is in the field of myeloid malignancy and how to develop innovative therapies in the field to improve patients' outcome. His very important contribution includes participation in the several clinical trials in myeloid malignancy. He has had led many global clinical trials led to regulatory approval of novel agents in myeloid malignancy. Today, he's going to present very important and one of most common myeloid malignancy, low-risk MDS, and he will review novel agents in low-risk MDS and where do we stand. Dr. Badar, floor is yours. Thank you, sir.
Hi everyone. Thank you so much, Dr. Savani, for a kind introduction, and thank you for the kind invitation to present at this very prestigious forum at ICH. We'll be discussing today the new drugs for low-risk MDS and where we stand and what needs to be done to further refine our treatment strategies and sequencing strategies for management of low-risk MDS. So, starting with the overview of today's discussion, we'll go over the brief background, followed by the evolution of risk stratification as well as classification of MDS, which is important when you sequence therapy for, in particular, also for low risk MDS. Then we'll shed some light from some certain novel agents and excitement over the last few years, where we see several agents approved for low risk MDS. That has been not the case if you look at the data going back 10 years or so. Briefly discussing the target therapy approval for this group of patients, and then we'll summarize or take home message from our discussion today. So, background: MDS is a heterogeneous disease with varied outcome, characterized by ineffective hematopoiesis, leading to cytopenia, and variable risk of progression based on risk factors. It's most prevalent in US in ages 75 or 77, the median age. So predominantly, we see this in elderly patient population with annual age adjusted incidence in US is 400,000. It's a rare disease, but for physicians who deal with myeloid malignancies is one of the bread and butter for our daily practice. So we will briefly discuss the classification of MDS, which evolved over time. Initially, as you can see here, more or less it was based on morphological determine how we classify MDS. But later on, as the time progressed, we know that certain chromosomal aberrations or abnormalities can determine how our patient with MDS will do, as you can see here. And this lead to further refinement of risk assessment in MDS, incorporating the degree of cytopenias, chromosomal aberrations, and blast percentage. As you can see in the middle, the IPSS-R, until most lately, which conducting trials is the main enrollment. We, for the stratification of patients or to see the eligibility in participation in clinical trials, is mainly till now have been based on IPSS-R. As we are moving towards more molecular-based classification, this may change, but until now, until recently, with the approved drug, IPSS-R has been used for the stratification of MDS. So what are the advantages or shortcomings of IPSS-R? IPSS-R has been widely used and most feasible, where it's economically very effective in certain part of the world where there are some restriction in resources. And as I told you, it has been used in all pivotal clinical trials up to date. and has been validated and gold standard for prognostication. However, it does not incorporate somatic mutations, and which understate the significance of patients with normal cytogenetics. More than half of the patients with normal cytogenetics may have a high-risk disease based on their somatic mosaicism or somatic profile. This was the earlier studies in which they try to show that individuals with low risk MDS may have a variable outcome based on somatic mutation, incorporating data close to 300 low intermediate 1 patients. As you can see here, EZH2, RUX1, PIV3, and AXL1 were determinant of inferior survival outcome. Later on, most recently, the IPSS-M, using hematological parameters, cytogenetic aberrations, somatic mutation of 31 gene panel, devise a IPSS-M model, which is predictive of response incorporating somatic mutations and tends to do better than conventional IPSS-R method, which has been using for certification. Those with SF3B1 mutation tends to have a favorable outcome, and those with multi-hit PU3, FLT3, MLL were predictive of adverse outcome. So IPSS-M is more precise prognostication tool, and it can upgrade 50% of intermediate disease, is better used for secondary or therapeutic disease, which are more enriched in high-risk mutation. It has been validated. However, it has been expensive and may not be feasible in certain areas of the world where the resources are restricted. However, having said that, there's still some room for improvement as it does not account for allelic burden for various somatic mutations that could be predictive of outcome, as well as different somatic variants. Some of them may have a better outcome compared to those within particular gene mutation. Then we'll briefly discuss with you the revised classification of MDS. There's certain changes have been made to the MDS classification on the updated WHO 5 classification of the ICC, where certain categories are defined, such as MDS with fibrosis. In our daily clinical practice, we do see patients, certain subsets of patients who have marked fibrosis but doesn't have features of MPN. They are more dysplastic in nature in terms of their chromosomal aberrations or molecular mutation, but do have second fibrosis. These patients tend to have predominant cytopenias, high transfusion needs, and suboptimal response to growth factor support and so forth. Then the other category is MDS with mutated PIV3. We all realize PIV3 mutated myeloid neoplasm tends to have a differential uh, outcome based on therapies and tends to have a very dismal outcome, in fact. And the other category, MDS with SF3B1 mutation, as we know, it not only has a diagnostic but therapeutic uh, aspects of it, as we'll learn later in this our presentation today. And the subcategory of MDS AML, where you see a blast percentage more than 10%, but these patient doesn't have a pathognomic MDS or AML defining molecular aberrations, but have a high blast percentage. MDS AML is a new category introduced by ICC with intention to help enrollment in clinical trials of those with high risk MDS as well as AML. So we'll go over a real world case scenario, and we'll like to evolve our discussion based on this case and how we sequence our therapies for in this particular situation. So I'll present a 61-year-old lady with transfusion-dependent anemia and CBC revealing hemoglobin of 7, white cell count of 4.7, and platelet count 325 with serum erythropoietin level 55. For anemia, worker bone marrow biopsy was done that showed erythroid hyperplasia with ring sideroblasts more than 15%. Blasts were not increased, chromosomes were normal. However, NGS revealed DNAMT3 and SF3B1 mutation. As per IPSS-R, this was a low-risk disease. So how would you treat this individual patient? Would you treat with Revlimid or lenalidomide, luspatercept, erythropoietin-stimulating agent, or imetelstat? So based on the profile, patient was treated with ESA and hemoglobin was improved by 2 gram initially. However, 9 months later, after stability in hemoglobin, we saw a drop in hemoglobin with counts relatively stable apart from anemia, and this time the EPO was more than 500. So this scenario where patient had initial response to ESA but now seems to losing the hematological response and with increase in EPO level. So at this point in time, would you change your management strategy, treating with lenalidomide, luspatercept, imetelstat, or hypomethylating agents such as erythritidine or decitabine? So we'll go over the Medalist trial. That was the initial phase 3 trial that was positive in which the luspatercept, which is a transforming growth factor beta fusion trap protein, neutralized the TGF beta and restored the effective erythropoiesis, which is impaired in MDS. It was a phase 3 trial enrolling patients with ring sideroblast MDS, IPSS are very low interval disease, transplant dependent or refractory to ESA. 229 patients were enrolled, 153 in the luspatercept arm versus 76 in the placebo arm, 2.2 to 1 randomization. The primary endpoint of that trial was transfusion independence at 8 weeks or longer, whereas the secondary endpoint was transfusion independence 8 weeks or longer. This was a positive trial in an ESA refractory low intermittent risk MDS who were transfusion dependent. Luspatercept was shown to significantly improve the transfusion independence not only 8 weeks but persistence, better outcome up to 16 weeks from the time of initiation of therapy. And that led to initial FDA approval for MDS with ring sideroblast or MDS MPN ring sideroblast thrombocytosis failing ESA. One thing to note in this trial, patients with MDS MPN overlap were not significant. However, the FDA improved based on ring sideroblast morphological category. The incidence of adverse events, the most common adverse event initially in the Medalist trial shown were mainly fatigue, asthenia, edema, and some GI disturbance, which tends to improve over time. So with this, since we saw improvement in outcome with luspatercept compared to placebo and ESA refractory, the subsequent trial, a phase 3 registry trial, was done in treatment-naive low-risk, interrisk MDS patients, where luspatercept was compared to ESA. The primary endpoint here was again transfusion independence, this time for 12 weeks, with concurrent improvement in hemoglobin for at least 1.5 gram. 356 patients were enrolled and randomized equally to ESA versus luspatercept. As you can see here, luspatercept tends to have a better transfusion independence and hemoglobin improvement rate compared to the ESA. As you can see here, although responses have seen across the board, but more predominantly among individuals with SF3B1 mutation or plus minus DN3AXL1-TAT2. However, patients who had a splicing factor mutation, RAS mutation, tends to have a suboptimal outcome with this therapy. This led to approval of luspatercept upfront before the Medalist trial led to approval in relapse refractory situation, this time upfront label for transfusion-dependent low intermittent risk MDS, non-deletion 5q with serum EPO less than 500. So, as I said, the treatment was tolerated. The side effects were the same as we saw in the Medalist trial, grade 3, grade 4 adverse event around 1% or so. And the adverse effects improve with time, what we have also seen anecdotally in the real world setting. More recently, at the last year ASH, Garcia Nero from MD Anderson presented the updated data, a long-term follow-up of COMMAND trial, where you can see here around 44% of patients maintain response for more than a year and 30% of patients maintain response for more than 1.5 years or so in terms of transfusion independence. The duration response median was around 154 weeks with luspatercept compared to 91 with ESA with significant p-value. So in summary, the greatest benefit of luspatercept upfront was seen among individuals with low transfusion burden, serum OPA level less than 200 with SF3B1 mutation. However, the effective treatment option for patients with RS negative disease, high transfusion burden with higher EPO level, it's still an area of unmet need where we need to strategize treatment strategy, how to sequence these therapies to improve outcome of our patients. Going back to the case again, same patient who had initial response to risperidone for 9 months or so progressed, becoming anemic. However, this time he was seriously some moderately leukopenic and neutropenic. However, the platelet count remained stable. Bone marrow biopsy was done, which revealed MDS with multilinear dysplasia. Myeloblasts were 2% compared to 0% initially. Chromosome is still diploid, and NGS is still showing same somatic mutation seen earlier. At this point in time, how would you treat an individual with MDS who prior failed ESA and luspatercept? Would you go for Revlimid, imetelstat, hypomethylating agent, or would consider bone marrow transplant? So the IMerge trial is another recent approval based on the positive phase 3 trial in which imetelstat, which is a telomerase inhibitor, a competitive enzyme inhibitor, telomerase enzyme has a activity in promoting the myeloid progenitor cells. When it comes to MDS, it leads to abnormal proliferation of progenitor myeloid cells and inhibit apoptosis. So imetelstat is a competitive inhibitor which helps in causing apoptosis of deformed or abnormal myeloid cells, leading to improvement in erythropoiesis. A phase 3 trial was conducted after initial positive results from the phase 2 trial in transfusion-dependent non-deletion 5q low-risk MDS who have prior response and then progressed or ineligible for ESA-based therapy. Remind you, these patients were Revlimid and HMA naive disease, randomized 2:1. The primary endpoint of this trial to achieve transfusion independence at 8 weeks, and secondary endpoint is to achieve transfusion independence for 24 weeks and improvement in hemoglobin improvement rate. So the primary endpoint was met with improvement in transfusion independence around 40% or so compared to 15% with placebo, as well as the secondary endpoint was also met with improved transfusion independence duration up to 51 weeks compared to 13 weeks with significant p-value. Correlative studies did show not only the transfusion requirements have been improved, decreased, or independence have achieved, also certain somatic mutations that are more prevalent in low-risk MDS, such as SF3B1, TAT2, DNMT3A, and AXL1, all have a decrease in VAV. How much it comes comes into play in terms of disease modifying ability of the disease is yet to be determined, but some expect to showing that it also decreased the somatic mutation burden. With this, two new agents which are approved back to back for management of low risk MDS, imetelstat as well as luspatercept, there is still unanswered question when it comes to low risk MDS. The role of luspatercept versus ESA in frontline setting based on EPO level. We all know at a high EPO level, luspatercept may be a better option, but what about ring sideroblast MDS low risk with EPO less than 500? Should we go for ESA or should we choose luspatercept? And then the efficacy of imetelstat in individuals who had prior luspatercept. Remember, in the IMerge trial, these patients had prior ESA. At that time, luspatercept was not there and wasn't given for those patients. So how your patient responds who had a prior luspatercept based on positive commands data is yet to be determined. And what would be the best frontline treatment option for high baseline EPO? Is it luspatercept or imetelstat? Yet to determine. I think a trial is ongoing, evaluating the upfront imetelstat in these scenarios. So there are a couple of abstracts which are presented at ASH last year. I would like to highlight them. A couple of them very prevalent to our low risk MDS category with transfusion dependence. First one, I would like to say the early versus late onset ESA support for our low risk MDS anemic patients who are transfusion independent. As we know, the label for ESA luspatercept has been based on transfusion independence. However, this trial, where the GFM group randomized patients to receive early versus late ESA. As you can see here, the eligibility criteria non-RBC transfusion dependent, low risk MDS patient with baseline hemoglobin between 9 to 10, right? And then they see the outcome. The primary endpoint was first time to RBC transfusion dependence, as well as secondary endpoint was quality improvement. So as you can see here, early versus late EPO did improve the duration response. However, it didn't replicate into better survival outcomes. As you can see here, early versus late. More importantly, and intuitively you think if you intervene early with ESA, you might see a better quality of life measures, but it wasn't reported. How the caveat is that the patient randomized for 40 in each arm. So a small proportion of patients, which may be a limiting factor, but to my surprise, there wasn't any improvement in quality of life measures with early intervention of ESA versus late among MDS patients who are anemic, may not be transfusion dependent. So, as summarized, as I told you, the next one is the combining ESA with luspatercept in non-ring sideroblast MDS patient having failed ESA, and this was a phase 1, phase 2 study called the Cambola study. So the study schema and baseline characteristics are as below. The eligibility criteria: low risk MDS, non-ring sideroblast. We all know ring sideroblasts tend to have a better response to luspatercept. Non-deletion 5q, and having failed ESA, luspatercept was combined with ESA. These patients were at the higher end with significant proportion of patients with intermediate 1 risk disease compared to low risk disease, and had a higher transfusion needs, as you can see here, higher transfusion burden. The response rate, the erythroid response, was around 30% or so in this group of patients with decrease in transfusion needs. The response are modest, but in terms of seeing that these patients are with high transfusion needs, something which needs to be further explored and going to be explored in a phase 2 study. After a little bit gearing up to a target therapy for MDS, recently there's a evocidinib IDH1 inhibitor are approved for management of MDS with IDH1 mutation. One thing to note that IDH1 mutation is not that common in MDS compared to AML, around 3% compared to AML, where you see around 10 to 15% of cases. In IDH1 mutated MDS, initial studies shown that more commonly associated profound neutropenia. So this study was done in which the dose escalation phase 1 study was done, enrolling a very small subset of patients considering rare nature of disease. In spite this study being a multi-center study, is still only 16 patient data was reported, showing very impressive response rate, complete remission rate around 44%. Remember, with HMA-based therapy, either azacitidine or decitabine, the complete response rate is in the range of 10 to 15%. So you can see a better response rate, and these patients were treated, including those with failing HMA-based therapy. And this another study, EDIUM phase 2 study evaluating IDH1 inhibitor MDS failing HMA or high risk MDS, also showed impressive response rate. With this, FDA gave a breakthrough designation and enrollment expanded, and with showing persistent improvement in outcome in a small subset of patients were very meaningful improvement outcome, considering these patients had a prior intensive chemotherapy as well as HMA based therapy, with remarkably improving the survival close to 3 years. Remember, individuals who failed HMA in the contemporary era, the median survival is a range of 6 to 9 months, which is improved close to 3 years with this therapy. So a very welcome addition for our MDS patients with high unmet need failing post HMA. However, it is only seen in 3% of patients. Can we use HMA-based therapy for our low-risk MDS patients? You cannot take away hypomethyl therapy for MDS. There several studies have been done evaluating HMA for low-risk MDS. One study showed if you modify the duration of MDS-based therapy from 7 days to 3 days in terms when it comes to azacitidine, or 3 days from 5 days when it comes to decitabine, you can improve the responses without causing increased toxicity or myelosuppression that could be challenging in elderly patient population, which is predominant for MDS group of patients, as you can see with improvement in response rate. So the message here is you can modify the duration of therapy to minimize the toxicity while without compromising the efficacy, utilizing a modified duration of HMA-based therapy. So this is the algorithm in the current era in terms of sequencing of therapy for low-risk MDS or intermediate risk MDS with IPSR less than or equal to 3.5, based on the symptomatic anemia, thrombocytopenia, neutropenia, and risk stratification. You can incorporate or sequence therapy as has been shown here and what we have discussed in our presentation today. So recommendations or takeaway from today are low risk MDS, ESA for symptomatic anemia, non-syndroblast EPO less than 500 still relevant, luspatercept especially for ring sideroblasts or non-ring sideroblasts with high EPO levels, is an option. Imetelstat is a new addition. Remind you that imetelstat can cause neutropenia and thrombocytopenia in two-thirds of the patients. However, good to know that with the continuation of therapy, these cytopenia improve over time, as has been shown in the IMerge trial. Revlimid is, is still the best drug when it comes to managing deletion 5q upfront rather than utilizing ESA or luspatercept. It has also been shown to work for non-deletion 5q, but the response rate are lower. But it's an option before if you want to avoid HMA-based therapy for as long as possible. And low risk HM, low dose HMA or IDH1 inhibitor is an option for the patients with this IDH mutation. And part switch clinical trial is always encouraged. With this, I would like to thank you for listening.
Thank you. Thank you for an excellent presentation, Dr. Badar. So we have received several questions, and I'm going to read in the order we have received. And I have consolidated several identical questions or comments. So let's start with some question on a natural history, actually. So what percentage of MDS patient in your patient, low-risk MDS patients, when you diagnose are transfusion dependent? And how they evolve? If they're not initially transfusion dependent, what percentage are transfusion dependent at 1 year or 2 years or 3 years after diagnosis?
Yeah, so predominantly at the time of presentation, these patients are low risk disease compared to intermediate high risk disease, right? And predominantly these patients are anemic. I can say you a ballpark around 10 to 15%, maybe 10% or so, may not be symptomatic enough to be intervened and can be observed for a little bit of time. But majority of the low risk, I would say 70 to 80% are transfusion dependent or having symptomatic anemia where you feel a need to intervene and start therapy. And in terms of for 10% of patients who have a low risk disease, based on their molecular chromosomal aberrations, that definitely predict how much time it will take for them to become symptomatic or progress to where you need to do an intervention. But I would say it will vary based on molecular profile and chromosomal aberration. We're in the range of 1 to 3 years, I would say.
Got it. Yeah. So next question is percentage of patients receiving LUSPA versus ESA in RS negative patients in your practice? What you predominantly use? Always LUSPA or you start with ESA? What is your current practice, sir?
Yeah, so I think if the EPO level is not high and RS negative, low risk MDS, I would go with ESA and defer luspatercept initially upfront, and will use luspatercept if we don't achieve a response or there's intolerance to ESA.
Perfect. Yeah. And now next question is, why most low-risk MDS studies patients enroll more RS positive than RS negative? Because in a clinical, in generally, we say RS negative is about 2/3, 1/3 is RS positive. On the contrary, most study, like you mentioned, command study, IMerge study, they enrolled almost 60 to 70% RS positive. Is it a deliberate attempt in a clinical trial, or was it this is how patients were referred?
Uh, it's hard to comment on, but you see, considering ring sideroblast and SF3B1 surrogate markers, right? And it may be more enriched the low risk disease. If you don't see a ring sideroblast, you may see a higher risk somatic mutation profile. These patients may not be eligible. So considering there must be some bias in it, but a low risk may be more enriched in a favorable somatic mutation, SF3B1 mutation. That might be the reason you see. And ring sideroblasts are predominantly more common to have symptomatic anemia or transfusion dependence compared to non-ring sideroblasts. So that could be certain maybe factors that have come into play. Yeah.
Got it. Yeah. So there's one question again. This is personal opinion from the person asking question. Impression is LUSPA works better in RS positive and low transfusion burden patient. So for high transfusion burden patient, what is your experience using frontline therapy, LUSPA versus ESA?
Uh, it's hard to differentiate between the two. If individuals have high transfusion needs, their response to ESA or luspatercept, I haven't seen a difference in outcome between the two. If you see the IMUSH trial, there were around 40% of patients had a high transfusion needs. And when you compare luspatercept or ESA, the responses were better. So I think for individuals with high transfusion needs, I think it will see how the trial goes, where they're evaluating the upfront strategy. For high transfusion needs, imetelstat may be a better option. Time will only tell based on the read of these trials which are ongoing. But in terms of differentiating between the two, I haven't seen any difference when it comes to luspatercept versus ESA.
Next question is on time to response, time to transfusion independency. What's your experience using LUSPA versus ESA?
Yeah, with luspatercept, I think it all depends on factors like transfusion burden, a degree of anemia, and uh, risk category. But I think at least takes around, I would say around 6 to 8 weeks to see a response.
So let's move on to next target. You mentioned about telomerase inhibitor. I'm telestate. The question is on, a merge consolidated one on side effect of I'm telestate or imtelestate. How to manage? Is it difficult to manage pancytopenia after I'm telestate?
In my clinical practice outside the trial, and
Mhm.
usually you can delay therapy for a couple of weeks, like it's a given every 4 week or so. And then if the
Okay.
thrombocytopenia is severe, you can delay therapy, let the counts to recover before initiate therapy. But if it's requiring delays in subsequent cycles, you might consider reducing the dose by 25% to manage the side effect. So that would be another way of managing it. As seen in the trial, the cytopenias, neutropenia, thrombocytopenia were seen around almost in 70% of patients for all grade, but tends to improve over time. So if you persist on therapy, modifying the dose, giving some four more bigger interval, you may be able to pass through that phase where cytopenias are more predominant.
So let's move to the failure rate. So there are several questions. What percentage of patients in your practice, once they start LUSPA, fail? 8-week transfusion independency or 12-week transfusion independency achieved. But by 1 year, what percentage of patients will fail that particular drug, LUSPA versus ESA versus imetelstat? So there's no standard. Some are first line indications, some are second line indications.
Yeah, as you can see, the follow-up data from the command trial, the 1 year response transient independence was around 44% or so, and 1.5 around 30% or so, compared to ESA around 20%, 19% or so.
Okay.
So I think it's not much difference in what I see in the clinical practice, where ring sideroblast tends to have a better response with low transfer needs. I would say it's more or less replicate. In terms of imetelstat, it's recently got FDA label, very recently, last year for us some time. So we haven't gone that far in terms of real world outcome, what we can see when they're losing response. But yeah.
So next few couple of questions on novel agent, elritercept, another GGF beta ligand superfamily trapper. Uh, what's difference between elritercept versus luspatercept in terms of MOA or possibly clinical efficacy based on early data of elritercept?
Yeah, early data I've went through. I've briefly, I haven't gone in great detail on this data, but it seems to be have lesser side effects, and it tends to work better in individuals with high transfusion burden compared to luspatercept. But it's a cross trial comparison. It hasn't been compared head to head. So the more number of patients, longer follow up, and randomized study would definitely tell. Well, I don't see anyone would compare luspatercept with this agent. It always be a cross trial comparison how the things work, but it seems to be better tolerated and a better efficacy in individuals with high transfusion needs.
High transfusion burden. Okay, perfect. Yeah. So for next clinical trial with all this new agent, what is best clinical trial you would recommend? You have done so many clinical, you participated, you led many clinical trial. What best next clinical trial based on availability of new agent, LRI and all that? What do you want to study? What do you want to study?
Yeah, I think the ideal scenario now we have these two newer drugs to approve. It would, as I mentioned earlier, further randomizing patients based on low transfusion needs and high transfusion needs, and high transfusion needs as well as EPO level, and then further utilizing upfront imetelstat uh, for those with high transfusion needs or high ESA, and looking in comparison to luspatercept. I think that would be moving Rytelo upfront in targeting individuals with high transfusion needs and high EPO and comparing those with luspatercept. I think that would be very interesting. But definitely for that comparison, yeah, best or dividing a trial, best physician's choice versus imetelstat in individuals with high transfusion needs and high EPO level. So I think that would be really beneficial in terms of targeting that particular subgroup which doesn't seems to do well with the available therapies.
Just one more question just popped up on disease modifying potential. Question is, any data on disease gene reduction, early burden reduction in low risk MDS patient with luspatercept? Are you aware of any data, or any disease modifying potential of this drug?
I think there was one abstract presented, I think at last year EHA, in which we the look at the somatic mutation allelic burden with Spitacercept. I'm not. I haven't. I'm not. It's not. It's not on the top of my head. So I've been looking at the data. But I think the disease modifying abilities we all see across the board in mild malignancies and so forth, where we do see some signal, but it really allelic burden making impact on how these patients behave in terms of progression survival, overall survival is yet to be learned, and we need larger sample size to determine that. But I'm not aware if luspatercept has shown to have any disease modifying ability. There is some correlative studies from the initial medalist trial where it shows that it also improves lymphopenia as well as thrombocytopenia. There's a letter which was published in Blood a few years ago looking at luspatercept has some impact on other cell lineage, but I'm not aware if the allelic burden is changed with luspatercept.
Last
Definitely, we have
couple of,
seen. Definitely, we've
go ahead.
seen that with imetelstat. Yeah.
Go ahead.
I'm saying that the allelic burden decrease among the commoner mutations. The IMERGE trial did mention that DNV3 and TAT2 mutation burden would decrease among those who responded.
Does it matter in a low risk MDS? Mm, Based on impression that most low risk patient don't die from the MDS, they die from comorbidity. Does it matter if we reduce burden?
Yeah, yeah, that's a valid observation. As you know, in US, the median age for MDS is around 77 years, and if they have a low risk MDS and the time to leukemia progression is less than 10% or so, and their median survival in the range of 8 to 10 years, then you have to play accordingly, right? So that's the main point where I see in the community practice, patient moves from one therapy to other or HMA based therapy, which is the last resort, quicker than expected. I think you have to play one day at a time and try to sequence strategies moving based on the pace of disease and comorbidities and overall. So more individualized therapy and making particular focus on quality of life.
One more question is on what is the reason for some patients in the placebo group getting transfusion independence in trial with luspain medalist and IMER study also? Small
Yeah,
fraction remain.
yeah. So yeah, no, I think that's very interesting. Like how these patients achieve a transfer independence. I cannot comment on that. I'm not. I cannot use my logic here.
So, Dr. Badar, this is the last question. Many of our 50,000 ISCH in email distribution list, we have so many from the developing country and still struggling with many of this drug because economic status. So this question is from Thailand. Hi, dear Dr. Badar. Thank you for comprehensive presentation of very actual problem. But that about treat low-risk MDS in low-income country where LUSPA is not available, there are any unpublished data about effectiveness about some other drug. Do you have any comments?
Yeah, I think no, I heard this comment, and it has myeloid diseases or cancer in general becomes more challenges in resource-restricted countries where these all novel agents may not be affordable to the patients or may not be available for these patients. I think uh, in those scenarios, it's very difficult. ESA is the go-to regimen. Sometimes I've seen if someone is not responding to one form of ESA, like Procrit, you may switch to RNS or Reticrit. You may able to achieve some response by switching therapies. That could be one thing. Uh, and then, if not, you can try a low dose HMA based therapy that is shown to work if you don't achieve a response to ESA and so forth. And but I think it's a challenge how to manage these conditions in countries which are restricting resources.
Dr. Badar, thank you so much for your time and thank you for all online attendees. The numbers are almost same like when we started a webinar. Again, those who are not able to make to the live webinar, this recorded session, which includes slide, will be available online in next 24-48 hours. Again, thank you very much for helping with the ISCH mission. Again, ISCH is a scientific interest group devoted to promotion of all aspects related to clinical hematology, including translational and clinical research, education, and dissemination of knowledge. Again, thank you all, and particularly Dr. Badar. Again, thank you so much.
Pleasure is mine. Thank you so much, Dr. Swani. It was wonderful to be part of this webinar.